Hey, good morning, Kansas City. I'm Dr. Stephen Stice, Chief Medical Officer here at the University of Kansas Health System. We are broadcasting live with you from the Dolph Simons Family Studio on this cold, crisp Tuesday morning, and we are delighted to be back with you. We've all had our hats on. We're going to ask Dr. Norman to demonstrate once again his fantastic hat he's been having on this morning, which we think is actually a coronavirus repealing hat, and all of us should wear when he looks so darn good. And indeed, he is back with us. He's going to update the virus variant as well as vaccine rollout across Kansas. Let us know how things stand. Before we go there, Hawkeye, how you doing?
Yeah, I'm good.
So, Hawkeye, are you the reason we did not win the Super Bowl?
No, I didn't jinx.
Okay.
Unlike that college football Dr. Pepper commercial, I did not jinx anything.
Okay. Well, I think we were really much closer in this game than it's. I mean, Mahomes was running for his life. We got a lot of injuries on the line, but gosh darn it, we were still pretty close. And the referees, I think they go to the Tom Brady school of officiating. Yeah. Not to mention next year we're going to beat them, and we're going to take away Tom Brady's Geritol. We're going to see how he plays then. How are the stats this morning?
You know, our stats here at the health system are actually pretty good. 29 acute infections in the hospital.
That's up from 2 yesterday. So still good. We're under 30.
We are under 30. Overall, our numbers are good. 11 of those, 29 in the ICU, 5 on the vent. 49 still in that recovery period, but overall, 78 total patients in the hospital.
Which is a hold from yesterday. We like that. That's good news. So we're still doing a lot better than we were.
And I'm seeing a patient on the floor, and he feels much, much better than he did a week ago. So he's in that recovery period. And
awesome.
That's good news for him. So.
It is good news. All right. So, Dr. Norman, where shall we start? Shall we start at the very beginning? I hear it's a very good place to start. You want to give us the latest in the viral variant and update on the vaccination rollout? Your call.
Okay. Good morning. I can do it, and I'll do it in that order since it was requested. Yes, we've talked about the various variants, and I know Dr. Hawkinson and you have also, and we knew it was just a matter of time. And indeed, last week we isolated the B117 variant in Ellis County, and that's the UK variant, as it's referred to in the press oftentimes. And interestingly, it was found through routine testing of an athlete. You know, we've talked a lot about how to keep schools going, how to keep colleges and universities safe, and we've been addressing this for months now. And this is an example of one that was found through routine testing, which is, of course, why we advocate for this. We went in that last week, toward the end of the week, with one of our brand new mobile testing laboratories, a strike team of individuals that came on site, tested about 200 people that were contacts or might have been contacts of this particular individual. And curiously, and it's very encouraging, we only found one positive test out of those 200 samples that were done. That test result, that sample, I should say, we've of course sent back to our state lab, and that was run at the end of the day yesterday to see if it was the genomic sequence of the 117 variant. I don't have that information right now. I will know it later today. Also, very curiously, you know, when we've talked a little bit about it, we've been doing wastewater testing of the water treatment plants. And it was interesting that in Ellis County, the week prior to the isolation of this particular variant, we found an uptick in the number of genomic fragments in the wastewater. And it's exactly why we do it, is to put us more on alert that there can be, whether it's a variant or just the regular COVID-19 we're seeing, it's an early indicator. When the wastewater starts upticking in terms of the amount of viral particles, then we can look in a more detailed manner in that community. So on balance, I think that is everything came out pretty well, but of course there's a long period of time until which we kind of breathe a sigh of relief in this particular county. And we're still doing more testing. We've doubled our whole genomic sequencing capability in the state lab. We'll now be doing probably right around 350 samples from all over the state every week, representing all the corners and counties of the state. Keep an eye on not just this 117 variant, but anything that might pop up by way of a change in the virus. I might comment on the overall state. Dr. Hawkinson reflected what's happening at your hospital, and that's what's happening around the state. Not only at other hospitals, large, medium, and small, but the numbers are coming down in terms of new cases, hospitalizations, and deaths. We reported yesterday, over the Friday to Monday, that's 3 days, 1,398 new cases. That's not a trivial number, but when you look at that, that's about 450 per day. And when you'll remember when we were at 2,000 cases a day. So that's a dramatic decrease, 96 deaths. Deaths are a trailing indicator, obviously, because we either find it through our surveillance into our data systems or through a review of death records. A total, therefore, 282,000 cases in the state of Kansas and 4,197 deaths. So we still have our hands full, but the vaccine is rolling out, and I think in a very good way. I'll be brief. The overall numbers, we've recorded 317,088 administered vaccines. We know that's a low number. We know, for example, and the data has plagued us, I've talked about this before, that with so many hundreds of vaccinating sites, getting the data in has been very difficult. And then, of course, IT is always a nightmare in the sense that the HL7 interfaces and gobbledygook that I won't go into makes it hard, so we have to double enter. So we know that, for example, 6 counties account for about 100,000 of the doses that have been given, and I want to emphasize have been given, but are just not recorded in our data systems yet. Skilled nursing facilities and assisted living through the National Pharmacy Program coming great. Matter of fact, we're going to finish the first round of clinics in SNFs because there's been 82% of the residents have been vaccinated at least with one vaccine. That will wrap up by the end of the week. The second dose clinics in skilled nursing facilities will continue into March, just because that's how long it'll take to get the second dose, 3 to 4 weeks out. Retail pharmacy program through the federal government has started this week allocated to community pharmacies around the state. They might be some of the bigger outlets like Walmart, but also the smaller and independent ones as well. So you'll be able to watch that on our website, thekansasvaccine.gov. There's a banner up at the top that says "Find My Vaccine," very cleverly named, and yeah, there you go, up at the upper right hand there, "Find My Vaccine," and there's a map that shows where the vaccinating sites are and where are the ones that have vaccine. So far, we've got many, many, many more vaccinating sites and vaccinators than we do vaccine, but I'm optimistic that we're going to start seeing an uptick in the amount of vaccine coming into the state of Kansas. We're hearing things about production being faster, so keep an eye out for the Find My Vaccine site to be populated. It will have retail pharmacies. I think we're going to put it up today, maybe, or hopefully today or tomorrow, an additional map that shows what the community pharmacies are that are in the federal program that receives allocation from the feds directly for the vaccine. So with that, Steve, I'll turn it back to you.
Thank you, and thanks again for all your great work, Lee. So appreciate it. I know you get a lot of sleepless nights and long days, and are going to deserve a break after all this. So as you look at that, you know, of course, health systems are curious, and you know, we always try to advocate, hey, can we help? Can we give some vaccine too? Since that's something we kind of operationalize on a daily basis. So I just wondered, is there a role for health systems across the state, especially as vaccine production ramps up, and hopefully we're going to be seeing a lot more of it?
Yes, most definitely, Steve. The one thing about the hospitals and health systems is that you're accustomed to doing things in what I would call a mass vaccination methodology. You know, you guys I know can do 1,500 vaccines in a day without really breaking a sweat. And I think that's really great. We try to use our local health departments because we've always used local health departments for administering vaccines. They're very accustomed to distributing it. So the communities that are doing the best, and I know this will be true going forward, the communities and counties that are going to continue to do the best are those that have a good relationship between the hospital or health system, the local health department, perhaps the safety net clinics, and then ultimately with providers and medical groups, independent medical groups and the like. So I think that we would continue to encourage to have good, tight relationships at the local level. We're already distributing to hundreds of places for the vaccine. And this way we make sure, because we want to remember that we also, and you guys are so good at going and getting into the communities that are the most difficult to serve, whether they're older people, for example, that are essentially shut in, but they're not in nursing facilities, whether it's racial and ethnic minorities, whether it's small group living homes that aren't registered with the state. We may not know about them, but they're your patients, and you know where they live, you know where they are. Ditto that for pharmacies. Pharmacies have deliver drugs, deliver medications to people's houses. So this will take a lot of, and particularly in the difficult to serve populations, it'll take a lot of work and cooperation. And thank you guys for doing it, because I know you're willing to stand up and do
We're
it in
any
large
place we can help. That's our goal. We want to help. And I think most health systems, when I talk to my counterparts at Olathe and across the state, or Stormont and or Shawnee Mission Advent, or any of those, I think St. Francis, everybody, Hayes, they're all willing to just say, how can I help? And I think Hayes has done a great job. You look at the work they did with their FQHC, health department, and the health system together. They're working and using, I think, an abandoned grocery store, if I remember the story, or something like that. And they went in and they set up a whole vaccines clinic there and did a lot of vaccines together. So that's the example, I think. And we all have a role to play. We want to make sure we play the role. We want to get those arms. We want to get those arms just a little sore from that vaccine as soon as possible. Lee, when do you think the vaccine uptick will take place? And I keep hoping, Johnson & Johnson and Novavax have not gone up with their EUAs yet. They said they were going to, but I keep waiting for them to submit.
Right. I think there's going to be a gradual uptick in the existing vaccines that we now have, but the larger incremental jump will occur when we have more vaccines. And especially when you think of the Johnson & Johnson with the one-dose regimen, I mean, that will be a huge advantage, and especially for certain populations. There are certain populations that are very mobile. We have lots of homeless people, and what an advantage it would be to be able to give one shot and have it be done with that particular population, for example. And we will continue to look for those from a diversity and inclusion perspective. We are going to continue to work very hard to find those populations as well. So I think it will be for a few weeks at least before we see a dramatic increase, but I think we'll, even within the next few weeks, could see a gradual increase. Will it keep up with what we need? No, heavens no. But we will keep doing what we're doing in terms of the allocation out to the counties. By the way, the county allocations are on our website. It's not a secret. Yep. You can go to the kansasvaccine.gov and you can see it there right in front of you.
Well, and I'm hoping that come April's when we're really going to start seeing a big ramp up. But I am a little puzzled, and I don't know, Hawkeye, if you have any thoughts about, I thought the J&J EUA was going to go in pretty fast. And they kind of released the data in a press release and said, hey, we're going to be going to the FDA, but I don't think they've gone to the FDA yet. And so, not that I've heard.
Yeah, I don't know if they've applied already, but I heard if it does come, it's not going to be for another couple weeks before it's even reviewed. So I think we were hoping a little bit more of an expedited process with this, like Moderna and Pfizer. We just haven't seen it. And of course,
and maybe they're there and we just don't know because they haven't published it. I don't know.
Yeah, but I think it'll be another couple weeks. But again, the Novavax vaccine as well, which was that pre-fusion, that protein, we're looking for those as well. We do need to make sure they're efficacious, though. We saw the pause with AstraZeneca in South Africa. So I think that's the other key. But I think we do have that time right now if we can get them with the application, and if the data looks good still and they're approved, and we can roll out as many vaccines as possible to as many people as possible.
Well, Jill, let's see if there were questions from reporters first.
Good morning, Cody Holyoke, Channel 9.
Hey, Cody.
Hey, guys. Question for Dr. Norman about these pharmacies, community pharmacies, you said, getting these doses. Obviously, that's a great first step in trying to reach more people, but realistically, with supply issues, I mean, how many, just ballpark, how many shots are actually going to these pharmacies? I mean, you're spreading, what, 8,700 shots over, I think it was quoted as like 36 counties, Johnson County was saying?
Yeah, that's just a drop in the bucket compared to what we need, because we have 82 pharmacies that are included in that, so that's not many doses per pharmacy. Although, pharmacies are not traditionally high volume throughput for vaccines. When they take about 15 minutes per dose and they have one person at a time, that's the model that a lot of them have. They cannot be relied upon for high throughput unless they redesign their model really for giving it. What this is, and I think, Cody, it's a good question. This community pharmacy or retail pharmacy program comes through the CDC, which is different than the other things that have come through Operation Warp Speed. And the CDC is really on top of this retail pharmacy. And I think this first small allocation is really, as one of my colleagues described it, kind of a beta test to walk before you can run, to make sure that the distribution is working okay. I'm hopeful that the CDC, and particularly with Rochelle Walensky at the helm now, as the new Biden appointee, she's top notch. The whole team is. They've been kind of sat upon, I think, a little bit. I have a lot of optimism for the retail pharmacy program because a lot of those smaller pharmacies, especially, are in communities that are hard to reach. So I remain optimistic, but to your point, we need a lot more vaccine.
It is a pleasure, just to follow up, Lee, to see such really good people in charge of the vaccine program. And I think one of the things they're finding is that things were pretty disorganized when they arrived, and there wasn't much of a transition, and so they inherited what they inherited, and it was a little, I think it was a little disconcerting that I'm kind of a middle road guy, but a little disconcerting that we weren't a little better organized.
I think there's a lot of that. And also the other thing, it is not very exciting to talk about, but the data systems have just been awful. There's a whole new Tiberius system at the HHS, which is brand new and has a lot of growing pains to go along with it. And so to have a system at a state level, which we always have and always will have, that tries to talk with different federal systems has been clunky. So information management has been tough.
Yeah, and as anybody who knows where Tiberius comes from, James Tiberius
Right.
Kirk, and we all know that when he was young, he was a little bit of a rambunctious young man. So maybe that new
We all know
software
Captain
will be
Kirk,
like
yeah.
that. Yep, okay. Let's go. Live long and prosper. All right, Jill. All right, any other reporter?
Sorry, quick follow-up. First
Sure.
off, they got to maybe pick from a different show if they're going to do all these Star Trek references.
Oh, no, Cody, no.
No, it's fine. No,
Yeah,
I love
may the
Star
force
Trek.
be
But
with you, Cody.
yeah, there we go. Oh, wow. All right. When we talk
Go
about
Chiefs.
one more on the community pharmacies, even the Walgreens up the road from where I live has kind of retooled their layout, and I'm curious if Dr. Norman is seeing any of these pharmacies start to build toward being a sort of vaccination hub. Are there talks or anything like that going on in especially the rural communities?
Yes, that's the short answer. And because they've had a long time to ramp up for this, we've been talking about it for months now. And CDC has been working the retail pharmacy side and working with the large ones like Walgreens, CVS, Walmart, et cetera, but also the associations that represent smaller groups. So how they choose to do that is very much up to them, but we're hoping that they will be able to flex up as more volume comes in. They've had plenty of time to work it.
Anything else out there, Cody? All right. Any other reporter questions? Hearing none. Jill, you're on. What do you
All
got?
right. We have the best audience ever. They have got great questions today. Matt wants to know, Dr. Norman, what is the rate of ramp up that we would have to have across Kansas in order to get back to summer fairs and fall festivals and baseball and weddings, or is that number even achievable?
Well, it's not achievable at the current rate of vaccine production and delivery. But it is achievable if we would have 5 times the amount of vaccine that we have right now. You can figure out that if we're doing 80,000 doses a week and we've got 1.7 million people that will want the vaccine, I don't have my calculator in front of me and I'm not going to do it in my head, it will take a long time to get there. So it's just a matter of doing the math. Children, those under the age of 16 are not eligible for a vaccine yet, although that could be coming. There is still going to be a certain rate of refusal. So it's not like we're starting with an N of 3 million people and then dividing by the number of doses. It's going to be a smaller population than that, but at 80,000 doses a week or something, it's going to take a long time to get there. So yeah, we need more.
And just to say, on the New York Times, on the open access part around coronavirus, there's a nice graph about the current rate of vaccination that says at the current rate, which is about 1.4 million people a day, it will take till December the 10th in order to get everybody vaccinated. So that's approximately a very long time. And about that time, it's going to be time to give everybody their next round of shots. And so, we got to speed up the timeline. The only way to speed up the timeline is to have high production. The only way to have high production is get both Moderna and Pfizer ramped up, which is great because they have such high efficacy, but trying to get these other players to the market. And let's not forget, there's approximately 20 or 25 other vaccines behind the ones we talk about all the time that are in trials at different parts of the United States. So we're going to get more vaccine in the market. I think it'll continue to be very effective. Novavax looks almost, actually is as good. It's 90% effective, so it's really good. I think we're going to see all of them playing a pretty big role. It's just going to take a while to get them approved and then production up to the point that we get it. And I think in a few more months, here's my prediction. My prediction is we're going to have a different discussion. Our discussion right now is centered around, really, there's just not enough vaccine. We can boil it all down. People are mad, people are angry, but the real problem is there's just not enough vaccine. And as we ramp up, the next problem is going to be the logistics to give that much vaccine and get it all entered into the database, which we got to clean up.
And for Pfizer, did put out a press release saying they could ramp up production to create a batch within half the time. So
yeah,
if that happens,
we hope so. We hope that's right. Moderna will be right behind it,
Yeah.
and Pfizer said we're going to ramp up production. We're going to put 6 doses per vial instead of 5. Oh wait, we already do.
Okay, so one of our viewers wants
Hey, Lee, go ahead.
Oh, I'm sorry, Jill. I just wanted to ask Dr. Hawkinson a question, because one of the questions that will occur, it already is occurring, is can we get creative? What happens if one of the vaccine producers really is able to ramp up and the other ones don't? Can the second dose be something different than the first dose? Should we be using, because that first dose I think is really important to get one dose into everybody. That at least jumpstarts things. At what point do we give out all of it as first doses on the promise that the second dose will come? Can it be a different dose? In other words, how much wiggle room, how much creativity you think we're going to be? I realize you're not the FDA, but how much wiggle room will we have, and what science makes sense to allow for that creativity?
Yeah, I think thinking about the mechanisms, we don't know. Again, the guidance is don't mix those doses unless there's extreme circumstances. But to your question, we know AstraZeneca is working on a mixed dose trial, looking at I think AstraZeneca's number 1 and then Pfizer's the second dose. Can we, again, as you said, that first dose is important for ramping up your adaptive immunity, your specific immunity toward the virus. I would think that there's probably less of a problem if we're talking about the mRNA vaccines because they are just the spike and they seem to be the same spike. There are none of the variant spikes right now. As we get into this, I think there is that possibility that could happen. We just don't have the science behind that. But even with say the J&J vaccine or AstraZeneca, which we know are an adenovirus vector with the spike protein that they encode for. So you're still creating an adaptive immune response to that spike protein. That may be something down the road. We just don't have the science and the data to support that, but there could possibly be a mechanism. And again, what is the efficacy behind that? What is the safety? Those trials are starting to be enrolled in, specifically for AstraZeneca and Pfizer, mixed dosing. But I definitely do see a mechanism there if you need to, especially with Moderna and Pfizer mixed first and second doses.
Yeah, and I know there's talk about ongoing studies looking at that question. My gut says to me it's going to work.
Yeah.
Because what you're doing, especially, I think Pfizer and Moderna especially, to mixing those two, I think it'll be interesting to see the data around can you mix a J&J and AstraZeneca with Pfizer or Moderna or with those two. And so more to come, I expect.
Okay, so one of our viewers said that J&J did submit for their EUA application on Friday.
Excellent.
And
Excellent. I missed that, so good.
And Dr. Kevin Ault, who's our OBGYN, who is also on the CDC ACIP committee,
Yep.
had told me that he had expected at their meeting that's either going to be on the 27th or 28th, that they would take it up. So he is booked already on the first Monday in March to
Awesome.
talk about J&J.
Awesome.
So there's that update. Here's a question. If Debbie wants to know on the ramp up, how do they do that? How do they just make up more vaccine? And she's also concerned about the vaccines being synthetic. She read that people died after having the vaccine. Can you address
so
all
let's
of that?
just say, so first of all, we've given over 16,000 doses of vaccine here at KU. We have not had a single death from the vaccination. And you can go around, look around nationally, there's nobody dying from the vaccination. That's part of that internet lore, if you will, that is just not true. On the other hand, we have had over 440,000 deaths from COVID-19. That is true. And so there is absolutely no comparison between those two groups. And Lee, have you heard that too, the vaccine lore?
I agree with you, Steve. I think there's two kinds of misinformation. One is just people passing along things they've heard, and then there's also very deliberate misinformation and undermining the process. And the former is more forgivable than the last one. But I'll tell you, we are a member and participate in and always have of the Vaccine Adverse Event Reporting System. And that's when anytime there's an adverse effect from a vaccine, it's reported in through that system. And there have not been rising to the top anything other than just the things that we've talked about with local swelling and those kind of things. Have there been people die after the vaccine? I'm sure, but think about it. We're immunizing people in nursing homes that are 100 up to 108 years old, but anything that's related to the vaccine per se, no.
Yeah, the problem is that, right, do people die after receiving a vaccine? Well, of course they do. People die after taking a breath. People die after parking their car. People die after eating lunch. That's just part of normal human existence. Is there an increased rate of death that's related to the vaccination itself? No. Is there an increased rate of death related to COVID-19? Absolutely. I mean, again, these two things they're really not even comparable.
Yeah, and as far as ramp up goes, we know for that Chinese vaccine that is the inactivated virus. So they actually have to grow up large vats and volumes of infective virus, and then they inactivate it through a chemical process. That is much more difficult than the process that they have for Moderna and Pfizer. Again, those are proprietary, so we don't know the details, and we don't know how big those batches are, but they are synthesized in the lab. The lipid nanoparticles are, the modified RNAs are as well. It is safe. It has proven to be safe. So I think to ramp up that production, what you need is just more components and more square footage to get those components in a laboratory so that you can ramp it up. So it's that simple as just getting more resources to be able to do that. Certainly we know from the Novavax vaccine, which is that pre-fusion. I believe a lot of that is grown up in insect cell culture, so that's a little bit different as well. But I think if you're not growing up a live virus and then inactivating it, creating these modified RNA viruses, it's done in the lab. It's a synthetic process, but it's a synthetic process that has been going on for decades of creating mRNAs and things of that nature. So it's not the new process either. It is safe, but it's just a matter of getting those resources, getting those increased components in that square footage so that you can create that in the lab.
Jill, other questions?
Joellen wants to know, a phrase that she hears repeated by our panel frequently is, we will know more in 2 weeks. So what do we know now that we didn't know 2 weweeks ago?
Oh, that's an interesting question.
It is. I like Joellen's
We
question.
didn't do 2 weeks ago. I'll tell you one thing we know more now than we didn't know 2 weeks ago. What an impact the rate of vaccination or vaccination of our staff has had on employees being out. So our number, oh gosh, I want to pull this out of my head. I'm probably gonna mess this up. But the number of COVID positive staff members right now in our health system has dropped by 80%. And the answer is we vaccinated 80% of our staff. And so that's just proof the vaccine works. And I think it's a good proof. And we didn't know that 2 weeks ago. You know what else we didn't know 2 weeks ago? We didn't know the impact of how well people were going to be doing on infection control. 2 weeks ago, we still had really high numbers of COVID positive patients. Today, we are down to 28, 29.
Yeah.
So what does that tell us? that tells us that when people follow the rules of infection control, and we got a vaccination program rolling out, then we can control this spread of this virus, and we can be thinking that is a story of a light at the end of the tunnel. You know, we're going to have COVID-19 around for a long time. But if we have 8 or 10 patients in the hospital with COVID-19 and okay, fine. And people are back out in society and going to the Royals games, going to the thing, you know, back to church, back to the restaurants, back to doing the things we all love to do, then at that point, if we still have 8 or 10 patients in the hospital, that's something we can live with, honestly. Because COVID-19 is not going to go away for a while. So I think the best news we've had, and something we would not have predicted 2 weeks ago, is frankly, I was not going to think we were going to be down to this low number of patients. And I'm hoping it's just going to decline.
And I'm going to piggyback on that. You know, it is a decrease in those numbers without a significant proportion of the population vaccinated.
That's exactly right.
So I think that really talks to and speaks to those infection prevention measures. And this is accounting for the variants which have been identified in the U.S. We know that they are out there. We believe that they have been in the United States and California and Florida really since November. Based on genomic studies and a published report on that. But we don't see that overwhelming surge. And so why is that? I think it's because of the behaviors, and it's a behavioral disease at this point. If everybody can continue to do the masking, the distancing, not meeting in large groups, not interacting with other bubbles, that is the way to move forward until we can get a more sizable proportion of the general public vaccinated.
But I think the other thing that's really helped masking is it's just, masking as a political statement seems to have died. It needed to have never started, but it's at least died off a lot. And now I see people masking because they seem to know it's the right thing to do, and masking works. Lee, what do you know now that you didn't know 2 weeks ago?
Well, there's some of the same things you guys talked about, but you know, the retail pharmacy program, while it's just getting its, you know, training wheels on right now and will be taking off, was a glimmer in our eye 2 weeks ago. So that's a mechanism that has terrific potential to grow and grow some more as more vaccine. The other thing to not lose sight of is 2 weeks of safety information when it's coming at 1 million doses a day and 1 million examples a day. 2 weeks of safety information is dramatically comforting. And
I'm with you.
There we go.
That's beautiful. And hey, one other thought, and maybe you said this and I missed it. What's the percentage of seniors or of nursing home residents that have been vaccinated now?
82%.
Yeah, that's really good. And I actually think that's having a positive influence in hospitals already, too. I think the more we see of that, the better off we are.
Yeah, and I think to your point, too, about, you know, the hospitalizations, we understand there's going to be an equilibrium there.
Yeah.
When we do roll out these vaccines, the biggest impact they have is reducing severe disease and death. And
Right.
so if we have people in the hospital, we can, you know, do our supportive measures and our remdesivir and everything. But when we have the mass general population vaccinated, we can really cut down on those deaths, and that's an extremely important part of that.
I forgot to ask Dr. Norman if he had a hard stop today. Can you do 3 more questions?
Sure.
Okay.
He
And
likes
Neil-
us, Jill.
Yeah, we
Or
like
maybe
him
he
too.
likes you. I don't know about me.
No, I hope he does, but yeah. All right. Anil is asking, we remember Anil.
Hi, Anil Garbacher. I hope you're doing well, Anil. Hang in there, buddy. It's awful cold out there. Be careful. Be safe.
He said that he read some places where prior COVID survivors have a rougher time with symptoms on the first shot, and he wants to know, are we seeing the same on the second? I think he might have had his first shot,
All right.
so.
Lee, what do you think? Are people who have had COVID, are you hearing that they're having a harder time with their shot, first or second?
I think people have a little bit of a brisker response, yes. Has it been incapacitating or something that's required anything special? No. But I do believe, and I'll be curious also what Dana says, but
What you thinking, Dana?
with Moderna, most certainly, the second shot, people have more symptoms from it than the first shot. Is it a big deal? No, not really. Take some Tylenol and, you know, be lazy and get over it. I don't think we've seen as much with the Pfizer, but yes, if people have had previous COVID infections, they do seem to have a little brisker response.
Yeah, you know, I don't know. I would agree with Lee. I haven't seen any published data on that. Certainly anecdotally, I know people who've had the infection. They may have had some arm soreness and some fatigue after the first dose. and they were preparing for that or worse on the second dose, and they had really nothing on the second dose. So I think it is variable there until we see some published data, and it's anecdotal. But you could understand, just as Lee talked about, you can understand why that would happen. You've already seen that. You've already seen that spike protein. Your immune system your adaptive immune system is there. You have the specifics for the antibodies and the T cell responses to that, so you can understand why that would happen.
Yeah, I think that I hadn't had COVID. I had a nice brisk response to my second shot. Knocked me back for a day, but then I'm fine after that. And I think that's okay. I mean, that's just part of what we're going to have. And we ought to expect when we have an immune response, oh, wait, we have an immune response. And that can happen with Shingrix. It can happen with influenza. It can happen with MMR. And it can happen with the COVID-19 vaccine. It is not a reason to not get the vaccine.
So Christina said that she was watching Channel 4. Don't know whether it was in this market or in another one. They said the doctor was saying, absolutely, absolutely do not take Tylenol or ibuprofen or anything after your vaccine. And she wants to know what your thoughts, if you still remain.
Absolutely is a strong word.
Yeah.
I'm not sure I agree with that.
I heard they were going to ask that question. I don't see a mechanism for that, whether it's Tylenol, or whether it's an NSAID, which is a non-steroidal anti-inflammatory. If you are taking that for, say, 8 to 24 hours because of discomfort, when you have this immune ramp up going on after the vaccination that occurs for 10 days or 12 days or 14 days, and then you get your second dose after that, I don't see a real mechanism for blocking and stopping that. I don't see how that would happen and have long-lasting effects when we know that it takes some time for the vaccine to get to the muscle cells and then also get from the shoulder, the deltoid, and drain to the lymph node, where a lot of that immune selection is taking place. So I don't see a large problem with that. When we know that people took antipyretics, which means fever reducers essentially, during the studies as well, and we didn't see any of that. So again, just overall, I don't see a mechanism for that and having long-lasting effects if you're taking it for 8 hours to 24 hours to help reduce some of those symptoms. I just don't.
Lee, any other thoughts you have around that?
Oh, I agree wholeheartedly with Dr. Hawkinson. I would say that I don't think there's any good reason to take it preventatively because I don't know if it would blunt the immune response or not, but I don't think you should take it prophylactically. But maybe if a person has symptoms that are quite troublesome for them after they receive their vaccines, then that might be a reasonable thing to do. But I wouldn't take it preventatively.
Well, here's my self-confession.
Yeah.
Okay, so I'm going to tell you. So I took, as I tend to take naproxen before I get a vaccine. My shoulders always hurt, and I've had a couple of frozen shoulders. Like, I'm not going to have that happen, so I take some naproxen to maintain mobility. Okay, so the second time around, I said, I'm not going to take the naproxen. I'm going to try and just grin and bear it. I'll see what happens. And okay, so I took it the first time, got my second COVID-19. If you don't have an immune response, you're really not going to get sick from the vaccine, or you're not going to get all the side effects because the side effects are reduced from your. I had a heck of an immune response that second vaccine. So I took naproxen the first vaccine and had to wipe out my second vaccine. I'm telling you, my immune system could continually work. I'm not too worried about having had naproxen the first time around. And I think that's actually what most people would say. I think when we've had Dr. Paulin here from Mayo, the head of Mayo Vaccine Research, I didn't hear anything about don't take Tylenol or Motrin. Did you?
No, and again, you have to understand that your immune response is going to be occurring over those next 10 days. So really 10
up to 6 weeks afterwards, right? Your prediction, I mean, this keeps going and it multiplies on itself.
Now, if new data comes out, we'll certainly be ready to accept and look at that, but there's nothing. And we know that people took those types of medications in the studies as well.
Yep.
Okay, Carol and Jan want to know from Dr. Norman, have you provided guidelines or protocols to CVS and Walgreens regarding end-of-day shots so that they don't waste? And in any kind of criteria, these people are signing up wherever they can to get a shot and they're waiting to hear.
Yeah, we are seeing occasional, what I would call pop-up clinics, because these things do come in certain number of vials to distribute 100 vials of Moderna or 975 vials of the Pfizer, for example. And no matter how much lead time the vaccinating sites have, they do end up with sometimes just having an odd number of doses at the end of the day. And then you throw in the 6 doses coming out of a 5-dose vial, which is great, by the way. There can be that. So they have instructions and they have waiting lists that they maintain because We do not want anything to be wasted, and so far I think we've done very well with that. There are I'm calling them pop-up clinics at the end of the day, and be aware and be alert for that, and sign up and be on the waiting list, because you just might get a call and say, can you be here in 15 minutes? And I would recommend you do it.
And we've done that here. We're like, at the end of the day, we're going to waste a vaccine. Let's get on the phone. Who are we going to call? We're calling friends of friends sometimes, and it's just trying to get people in to get them vaccinated. So, okay, last question.
Well, Isaac wants to know, is the weather going to hurt any of the planned clinics?
We're open. We're not going to
Yeah, the health
stop.
Well, I think he wanted to know from Dr. Norman if that's going to
Dr.
be
Norman?
an issue.
This is Kansas, and Kansans are accustomed to lousy weather of all manner of kinds. But I will say it has inhibited the distribution because when roads are blocked, it's been hard on a few of those days. But basically, it's just a matter of 12 hours of delay and getting it to the next day. So even lousy weather hasn't impeded the distribution to the communities, particularly the ones out west where there's a lot of roads and not many plows.
Yep. Hey, just a little promo about tomorrow's program. Are you having trouble sleeping since the pandemic? Tomorrow, Dr. Nancy Stewart, a pulmonary critical care doc here at KU, is going to talk to us. She's also a sleep medicine certified physician, and she is going to share with us what she's discovered by following the sleep habits of frontline workers. I think that'll be a fascinating discussion. Dr. Norman, final thoughts for today.
Yeah, I can't believe you guys weren't doing cartwheels with enthusiasm over this wastewater treatment.
I think that's a pretty big deal. I love your wastewater. Yeah. I love it. I don't know if I like it as much as your hat, but I like the wastewater part. That's pretty good stuff. I have another question.
No, I'm not done yet about wastewater.
Go.
And the reason is because these wastewater, and I'm giving a shout out to our wastewater operators and our scientists. It's maybe not the most glamorous profession to be in, but these guys are unsung heroes of public health. And to have this intersection of wastewater with science as a predictor for what's happening with COVID-19 in the communities, I think we deserve a big whoop whoop for these wastewater operators.
Hey, but can you say, just to say, the reason we do wastewater analysis is you look for coronavirus particles in the wastewater to see how much coronavirus is out there as a measure of it, or a measure rises and falls in the types of genomic variation. So it is a big deal. Yep. Are you seeing less COVID-19 in the wastewater, or less coronavirus in the wastewater?
Yes.
That's a big deal.
Especially in the big metropolitan counties, we're seeing very much of a waning, and if there gets an uptick, we'll know that it's been very sensitive and very accurate, I might add. So I have a lot of faith in it.
I think that's a big deal. That part about just the wastewater information that it's dropped so dramatically, that's a big deal, which is kind of what we're saying. I think, A, it got cold. Nobody went outside and huddled up and all took off their masks. Okay, that wasn't smart. But B, even when they're inside, I think people are just behaving differently. And you see it throughout the community. You see it when you go into the stores. You see it around. And I think that's what's having an impact. We can bend the curve. We're doing it again. Dr. Norman, thank you for being on the program again today. Dana Hawkins, final thoughts?
Yeah, I like that. You know, the wastewater data is really pretty good, not just here, but in other countries as well, for maybe seeing an uptick more quickly than if you would just be doing the testing. So I think it should be, comforting to Kansans to understand that that is going on. It's just one more component that we can use to help identify specific spots or local infection dynamics maybe quicker than just overall testing. So I think that's good. Continue to do that and, go one day at a time. Hopefully we can continue to see a downtick in the overall rates of that.
The intersection of faith, hope, and science is powerful. And if you think faith in the rules of infection and prevention and control, hope that these rules are going to help get us through this crisis, science, which are going to bring us the answers and helping us all along. And you know what? Faith, hope, and science are going to bring the Chiefs back to the Super Bowl. Because don't you want to be there when we go back and kick the Buccaneers' tails and make sure Tom Brady feels like he really is 44 years old and strip away that Jared Paul? I do. And we're going to be back at it next year. As we close today, although the outcome was not what we may have hoped for this year, bring it on next year. The experience of going to the Super Bowl is still grand for the 18 healthcare workers from the health system who got to attend. Here are some of the memories they made. We'll see you tomorrow. Go Chiefs.